now we're going to talk about anti-inflammatory drugs, and this is quite a short chapter, but essentially, oh, can you guys see the arrows, or is that missing? I'm assuming it's missing because on my one it's missing. But okay, there should have been arrows between the membrane phospholipids, arachidonic acid, and prostaglandin H2. I think it's gone just because of where it's present. But yeah, so essentially I've included steroids and NSAIDs in here together, because what they do is they block these two enzymes called phospholipase A2 and cyclooxygenase. And these two are enzymes that are essentially involved in the conversion from membrane phospholipids to arachidonic acids, and then arachidonic acids to H2. And then that ends up forming these prostaglandins and cyclins and thromboxane that are very inflammatory. So examples of steroids is dexamethasone and beclomethasone. So they're both examples. And the way steroid acts on phospholipase A2 is not directly, but rather it acts on nuclear receptors, and in doing so, downregulates phospholipase A2. And so then there's less phospholipids being made into arachidonic acid, meaning that there's less inflammation. Now, COX enzyme inhibitors like NSAIDs directly inhibit COX enzymes. So the one in inflammation is normally COX-2, but normally these NSAIDs are non-selective, so they also inhibit COX-1. And that's why one of the side effects is that they cause hemorrhages, gastrointestinal hemorrhages, because COX-1 helps to basically form the inner lining of the gastrointestinal tract by promoting formation of mucus. And so if you inhibit COX-1, then you're preventing mucus formation as well as bicarbonate production. And then steroids issues is that whilst it's very good, it's important to constantly check the patient with using steroids, because it increases bone resorption, because it interacts with the osteoclast, and that's not ideal because that increases risks of osteoporosis. It decreases immune function, and it also causes hypertension because it promotes mineralocorticoid stimulation in your loop of Henle's, and promotes essentially reabsorption of water and potassium ions. Okay, the other one is antihistamines and anaphylaxis. Essentially, there's 3 steps to anaphylaxis. Anaphylaxis is the big word to say allergy reactions. Essentially, allergy reactions occur because of 3 steps. The first one is pre-exposure to allergen. So firstly, an allergen comes through and activates B cells to become plasma cells. And these plasma cells will make IgE because it's in mucus, and we'll talk about that when we get to antibodies. And then that IgE then binds to mast cells, and then the mast cells then will degranulate the second time that they meet this allergen, because the mast cells, the IgE on the mast cells will cross-link as soon as they again see the allergen the second time round. And when they cross-link, it causes degranulation. And one of the examples of things that is released when it degranulates is histamine. Now, histamine acts through H1 receptors, which are found on endothelial cells, on the endothelial cells, not just on the blood line, on the lining of the blood, but also found lining of blood vessels, but also on smooth muscle cells. And in doing so, it causes bronchoconstriction, vasodilation, and increased vascular permeability. And all that means that suddenly the person might not be able to breathe because they've got bronchoconstriction, and that's combined with edema. So it's hard to breathe. So the way we deal with it is we give them chlorpheniramine, which is an antihistamine. We give them high flow oxygen, and adrenaline to vasoconstrict and reverse hypertension. And then we give them steroids at the end to sort of decrease inflammation. So these drugs are very important in dealing with anaphylaxis. Now, chronic inflammation, I've included the diagram on the right because that is essentially how rheumatoid arthritis occurs. That there's some form of antigen, self-antigen, that activates T cells, and that goes on to activate B cells and macrophages, and then that leads to a bunch of actions that lead to large inflammation taking place within the joints. Now, if we consider that there's 3 targets of cells that if we target, we can treat essentially or maintain rheumatoid arthritis, that's important for us. So the one way we can do it is through DMARDs. We can inhibit all 3 of these using DMARDs, which are small biological molecules like methotrexate, gold salts, and sulfasalazine, which essentially promote an anti-inflammatory state and prevent T cells from coming through into into the joint. And in doing so, we're essentially preventing inflammation. These should not be confused with biologics. So these aren't biological therapies. So these aren't like antibodies. These are just small molecule inhibitors. Then there's biological therapy. So that's anti-TNFs, anti-ILs, anti-B cells, and anti-T cells. Now, if you think about it, if you have anti-TNFs, you essentially treat this macrophage activation, because TNF alpha is very important for macrophage accumulation and its activation. You have anti-IL-1s, which again, they prevent macrophages from releasing. IL-1 is one of the main things they release. And so it prevents IL-1's actions. And remember, IL-1 has a very systemic effect. So you want to reduce that. And then there's anti-B cells. So rituximab is one example, and that prevents B cells from being made in the first place. So it affects their development. And in doing so, it prevents B cells from even having a big role in rheumatoid arthritis. And then there's anti-TNF, anti-T cells, which are basically, so in this example, is abatacept, which basically prevents T cells from being activated. So if it prevents T cells from being activated, it prevents T cells from then going on to downstream effects of then activating B cells and macrophages. Whilst this was designed for rheumatoid arthritis, now it's been used for loads of chronic inflammatory conditions, and that's worth remembering. That whilst it's called DMARDs, which is disease-modifying anti-rheumatic drugs, it's used for loads of other chronic inflammatory diseases as well. So next thing we're going to talk about is repair. There's 3 stages of repair, essentially: hemostasis, acute inflammation, and proliferation and remodeling. And I've sort of shown a diagram at the bottom which sort of explains it really well. So hemostasis is important because you kind of want to plug the hole first as soon as there's a cut. And once you plug the hole, that's through a massive fibrin clot. Once you plug the hole, now you need to actually deal with if there's any bacteria inside, get rid of any cell debris and cell damage. And one way we first do that is we first dissociate all the blood vessels. So we get rid of all the blood vessels that are within this vicinity, and you can see it quite clearly there in the second little diagram. And once it removes all the fibrin, it then has a massive inflammation occurring, and that's where basically PMNs come in, and some macrophages come in, and yeah, and they come in and they promote these cells from the debris from getting removed, and also if there's any bacteria, from killing the bacteria away. So that's quite important. Now, once that's done, then these macrophages especially, they're very important because they start producing loads of these growth factors. So one of these growth factors, I've written actually 3 of them that you need to know for the exam at the bottom. They don't actually have like arrows, which is a bit annoying, but PDGF, VEGF, and TGF-beta are all examples of growth factors. PDGF is platelet-derived growth factor, and it's released from macrophages to an extent, and it promotes the how do I describe this? It promotes the chemotaxis of other macrophages to come in. So it's essentially promotes, it's a positive, it's a mechanism that allows for more macrophages to come in, to allow more inflammation to come in. Not just the macrophages, but also other endothelial cells, because you want to plug that hole at the top as well. If you see where the actual hole was, where the cut was, you want to also plug that through. But also fibroblasts, because you want to remake all that lost tissue because of the cut. And because fibroblasts make up the ECM, the extracellular matrix, you want to have more of them. Then you start remaking the blood vessels, and that's through VEGF. That's vascular endothelial growth factor. And that's important because without blood being there, without blood vessels being there, the tissue isn't being supplied, and so you risk it dying out. And plus, it also promotes more inflammation from occurring, because now suddenly there's another route by which macrophages and fibroblasts can enter the tissue from other areas. And then they start releasing another set of growth factors called TGF-beta. And these are very important because they actually cause the fibroblasts to start producing the extracellular matrix. And that is important for this granulation tissue. The extracellular matrix includes, if you remember from your first year lectures, GAGs, which is glycosaminoglycans, collagen 1, collagen 3. And so it basically fills that hole. And if you've noticed now, even at the top, there's re-epithelialization. So it means there's no longer that hole at the top in the epithelial layer. So now you've essentially plugged the hole, restored blood to the tissue, and now you form granulation tissue. Now at the end, you have to then remodel this tissue now. Essentially, if you've ever noticed, whenever you have a wound, it ends up becoming less like your normal skin, and it becomes a little bit harder, a little bit less flexible. And that's because of remodeling of the wound, where it converts collagen 3 into collagen 1. And so that collagen 1, if you remember from first year, is not as good as collagen 3 in promoting a flexible tissue. Essentially, collagen 1 is present in your bones, for an example, which is why it means your mature wound is a little bit different to your normal wound, to your normal skin. So yeah, back to Socrative, and then we've got one last section which we should whiz through. So yeah, let me just go on to the next question. Okay, so have a go at answering these next ones. Oh wait, actually ignore this. Actually, you could try have a go at this if you remember. This should have been asked in the beginning, but my bad. So if you remember, I talked about there was two sets of caspases. There was yeah, nice, very good. Yeah, so majority of you they've answered have said caspase 3, 6, and 7, and that's correct. 3, 6, and 7 is the main three caspases that are important at the end for cellular apoptosis. Okay, next one. So if you read the question, which one is not an adverse effect? Okay, so it seems like majority of you answered it, and this one is fairly skewed in these answers. So firstly, it's not A, and if you remember, the reason is if you use a lot of glucocorticoids or just steroids, because corticoids are steroids, remember that it promotes an inhibition of the immune system. So if you've now got a weaker immune system, surely it would mean that there's more opportunistic bacterial infections, right? So it can't be A. It would impair wound healing, because if you think about it again, inflammation is important for wound healing. If you just remember, you need inflammation in order for the PDGF, VEGF, TGF beta to actually be present. So if you don't have that, then you can't do wound healing. So impairment is another effect of extended glucocorticoid use. Osteoporosis is another one. If you remember, glucocorticoids like steroids act on osteoclasts, and it promotes their formation, and so it means more bone is being reabsorbed. And so again, that's another effect. So the answer is D, hypotension, because it causes hypertension because it promotes the uptake of water. So it should really lead to hypertension, not hypotension. Okay, the last one. The last question. Okay, it seems the majority of you answered. Yeah, so the answer is B, and that's perfect. Yeah, correct. None of you said really anything else, which is good. Perfect. Yeah, it helps deposit the ECM, so you need it for that. That's the main function. Amazing. Okay, fine. Now we're my 1 second. Okay, so right, let me just go to my slide. Okay, so so we finished talking about that. Now we're going to talk about specific immune response. It shouldn't take too long. First thing first, again, my lines are missing. Don't know why. But essentially, immune system is broken down into two things: innate and adaptive. Now, adaptive is formed from T and B cells, whereas innate is mainly physical differences and phagocytes, phagocytic cells like monocytes, macrophages, NK cells, dendritic cells. And the whole purpose is that once you detect PAMPs, then you activate adaptive immune system like T and B cells, which then go on to cause a reaction and then also help to maintain the immunity in future. So the second time round, you will be immune to the disease. So first things first is we need to talk about lymphoid organs. Now there's two types. There's primary lymphoid and secondary lymphoids. Now primary lymphoid organs is where basically T cells are made. They're made there and they mature there, and that's where we check that the T cells and B cells that are made are not self-reactive. That's called central tolerance. So in the primary lymphoid organs, there is central tolerance where we check that the B and T cells are not responsive to any self-antigens. And the way that works is that essentially there's positive selection and negative selection within the primary lymphoid organ, which means that it checks for the receptor, so TCR being T cell receptor and BCR being B cell receptor. It checks that they are not responsive to any self-antigens, and if they are, it would kill them off. Then there's secondary lymphoid organs, which is basically where the lymphocytes, like B and T cells, get activated. So the example I've given is lymph nodes, and a lot of questions would be related to these lymph nodes and where B cells are, T cells are, and where the antigens come through. So in a simple, in an easy way to remember this, those big circles that you see are called germinal centers. And they're where you primarily find your B cells. So that's within the cortex. So those massive circles. Now, if you see then there's a really tiny circle next to one of them. I can't point because I'm not sharing my screen per se. But essentially, there's a little one called high endothelial venule, if you can see on the diagram. And that's important because that's where most of the B and T cells come from. So like from the blood into the lymph node, they come through these high endothelial venules, and they do that through diapedesis. But you will also have antigen presenting cells, so like dendritic cells, and they will just enter through this afferent lymphoid vessel that you see. So they'll just enter through there because lymphoid is lymph nodes, is lymphatic systems, so it will just come through the lymphatic systems. And T cells mainly are originated in the paracortex, so in the purple layer, and then the inside, which is the medulla, is got B and T cells, and that's important because you need to know the localization of B and T cells in lymph nodes, which is what I wanted to say. They do ask the anatomy of this a fair bit, so worth remembering it like this because it sort of makes more sense, I guess. But anyway, so then we're going to talk about antigen presenting cells, given that we were talking about where they enter from. There's different types, the dendritic, macrophage, B cells, whatnot. And the way they activate is through two mechanisms, either MHC1 or MHC2. Now, CD4 cells, which we'll talk about, so CD4 cells are T cells that only have a CD4 receptor on their membrane. They require MHC2 to be activated. So if a CD4 cell binds with a antigen presenting cell, they need an MHC2 molecule that contains a small peptide on it to activate it. These MHC2 molecules tend to be related to the phagolysosome stuff that we were talking about before. The phagolysosome, once it destroys the pathogen, it then mounts a small part of that pathogen onto MHC2 molecules. There's also MHC1, which is expressed on every single cell in our body, and that basically samples our intracellular proteins. Because if you think about it, like if the cell becomes cancerous, or if it gets infected by viral infections by a viral component, then it's important that immune cells should know. So if it suddenly starts having a viral infection, it would have a small part of the viral protein being lodged onto the MHC1. Now CD8, so cytotoxic T cells need MHC1. And so it's called cross-presentation, where basically in cross-presentation, the dendritic cell will then send the antigen directly through MHC1 to then present. It's just a small technicality, but worth remembering. Okay, so then they're talking about activation of T cells. there's three signals essentially. One is a TCR and MHC complex that needs to form. So a T cell receptor needs to bind with an MHC. But that's not enough. It also needs co-stimulation with these other receptors. Now, CD28 is a protein that's found on T cells, whereas CD80 and CD86 is found on professional antigen presenting cells like dendritic cells. And without that, it leads to this thing called clonal anergy, which we'll talk about a little bit later. But yeah, and then the last thing is it needs cytokines. And the reason it needs cytokines is that if you look on the diagram on the right hand side, as soon as you have a naive T cell, it gets converted into one of these four different types of T helper cells. One is Th1, Th2, Th17, and iTreg. The differences are in how they act. So Th1 promotes cell-mediated response. They release a lot of IFN gamma, so interferon gamma, and that goes on to activate macrophages, and that goes on to macrophage doing its function. Then there's THC2, which activates IL-4, and that's more an anti-inflammatory mechanism. And then there's neutrophil activation, which again, IL-17 by the Th17 cell is important, and that's really important for acute inflammation, especially. The last one is iTreg. Now, iTreg is essentially an immunomodulator cell, so it basically inhibits inflammation. It prevents inflammation from taking place as much. And I've just left a little clinical relevance at the top, and that is that leprosy prevents Th1 from occurring and instead activates Th2. And if you look at the reason behind that is that by activating Th2, if you look, it releases IL-4. Now, one of the things that inhibit Th1 production is IL-4. If you can look on my diagram, it might be a bit difficult to see, but essentially IL-4 inhibits Th1. And so by activating Th2, it prevents Th1 from being activated. Now, Th1 is important to kill off leprosy, the bacteria are responsible because that lives inside of cells. So essentially, that's like a really smart way of sort of dealing with it. Okay. Now, in a similar fashion, there's also B cells. It's called a germinal center reaction, and the way it works is that B cells, once they become activated, they go into the germinal center, which we talked about, that massive circle, those circles within the lymphoid nodes, and then they will basically do class switching. So they will change their immunoglobulins from IgM to IgG. They will make their antibodies much more specific. So they do somatic hypermutation. So if you look on step 2, they do somatic hypermutation, which is basically where they sort of mutate parts of their immunoglobulins to make it have much higher affinity to the antigens. And that's important because if they're not very high affinity to the antigens, it sort of destroys the point of them being very well, being good at destroying these pathogens, because it needs to bind to them with high affinity. And so it constantly keeps like cycling through, coming from the dark zone into the light zone, then coming back to the dark zone until it forms immunoglobulins that are very high affinity. And that's important because you want to have high affinity. And some of them then go on to become plasma cells and then help the inflammation. And some of them then chill and become memory B cells. And in future, it will help when and if there is another infection. Okay. So we're going to talk about this slightly. Basically, there's two mechanisms of how immunoglobulins are variable and show diversity. I talked about somatic hypermutations. Essentially, if you look at those three little bands on the FAB portion of antibodies that I've drawn at the bottom, that's basically where somatic hypermutation happens. They're called CDR regions, and I will talk about them in the next slide. And that basically means that they become higher affinity to the bacteria or the virus or whatnot, and that promotes immunity. There's also VDJ recombination, which is basically where it's called, the D is in brackets because that's not present in light chain locus. So if you remember how antibodies formed, they've got two heavy chains, which are the two inner chains, if you look on the diagram. And then there's two smaller chains, which are called the light chains. Now, in order to make them as diverse as possible, in each of these chains, which are coded from a locus, they select for specific variables, specific diversity, and specific junctional domains, such that each antibody is different, each monoclonal antibody is different from each other. And so that helps to generate a massive diversity in the classes. Okay, fine. So I've sort of left this diagram, these three diagrams here, and this is the best way to class immunoglobulins. basically there's three sorts of class: monomeric, dimeric, and pentameric. Now, monomeric is IgG, IgE, and IgD. The way I remember it is GEP. Sounds like it's like a degree. And then there's dimeric, which is IgA, and then pentameric, which is IgG. Now, I've sort of left a box there, which basically illustrates all the important functions of each of them, and they are tested in the exam, and it's quite easy marks if you just memorize them. But essentially, IgG is found in secondary immune responses almost always, and that's the high affinity one it tends to be, and it's the most abundant one in the blood. And then IgE is anaphylaxis, which is when we talked about mast cells, that's what it was responsible for. IgD isn't very well understood. One theory is that it's important in B cell receptors in mature B cells, but that is actually one of the as a common sort of question in the exams. It's one of the common answers as well. So if you see IgD, you can think that's one of the answers. IgA is mucosal immunity completely. So yeah, it would be found within our throats, but also it's one way of giving secondary immunity. So the mother often gives the child breast milk, and the breast milk is important because it also contains IgA, which gives it a bit of extra protection. And then IgM, which is found in primary responses, immune responses. And it sort of makes sense because if you think about it, it's a pentameric one. Now that sort of tells me that it's a low affinity antibody because it needs so many binding sites to bind to a single, or like to bind to some antibody antigens. So it's a low affinity but important in primary responses. Okay. Now we're going to talk about peripheral immune tolerance and then autoimmunity, and then we should be done. So remember when we talked about primary lymphoid organs. Primary lymphoid organs was important because that primary lymphoid organs was important because that is where they made sure that any cells that were made were not reacted to self antigens. But if you think about it, when we talked about then about how the B cell then goes into the germinal cell reaction, does a germinal reaction, it sort of destroys the point of the primary lymphoid organs, right? Because if it suddenly starts mutating and then suddenly becomes self-reactive, because that's not tested and as such in the germinal center reaction as much as the central tolerance is in the primary lymphoid organs. So one way we prevent that is by having this peripheral tolerance, and there's three mechanisms: clonal anergy, apoptosis, and Treg in formation. So clonal anergy is what we talked about. When there's no co-stimulation with the CD28 and CD80, that's what happens. It stops reacting. It no longer becomes functional. Then there's apoptosis, which it basically kills off any cell. And what kills it off is the Treg. So the Treg cells will then bind to these any T cells or B cells. And if it detects that it's specific to self-antigens, it will cause it to apoptose. And so Tregs are really important because without Tregs, you're not going to have a peripheral tolerance. And that's mediated by this thing called FOXP3. It's a gene that basically allows for Treg conversion. And without it, it causes massive immune diseases, so autoimmune diseases, which is not ideal. Okay, the last one we're going to talk about is autoimmunity. It's not very well understood still how autoimmunity occurs. One theory is that if you look on the diagram, actually, that sort of very well explains it. An autoimmune cell is a product of genetic predisposition, so like changes such that it's much more likely to respond to self-antigens. It's much more likely that it's going to be missed out in the central tolerance, because AIRE, if you see AIRE, that's basically a gene that allows for central tolerance to occur, because it basically it codes for loads of peptides that tests that the T cell is not responsive to self-antigen. So if that's not there, if there's a mutation in that, then these T cells can escape and not actually be tested properly. Then there's also environmental triggers like infection, microbiome, traumatic insults that can also promote it. And the last one is defective regulation. So FOXP3 we talked about just now, that if that's present, if that's mutated, it means that Tregs aren't being initiated, and if Tregs not being initiated, then there's no peripheral tolerance. And that leads to these two sorts of sets of autoreactive lymphocytes, and they can do one of two things. One is make antibodies, so that's like myasthenia gravis, Graves' disease, or it can be what I talked about with rheumatoid arthritis, where it's cell mediated, because B and T cells will do cell mediated responses, and can also lead to insulin dependent diabetes mellitus, which is type 1 diabetes. That was essentially a big overview of immunity. But before we finish, can we go through these 2 questions and then we can finish off? So I've put on the next question. Okay, seems like most of you answered. So, correct. The answer is IgM and IgG. So, those are the 2 things that are involved in immune responses, mainly in the blood and in general. And so they are the main ones, IgG and IgM. And yeah, without them, complement cascade wouldn't basically run, at least a classical complement cascade. Okay, next one. And the final one. So think about it. Do cytotoxic T cells secrete IL-4 and 5? So, okay, it's definitely not A, because cytotoxic, remember we said, is CD8. It's not C, because they don't recognize glycopeptides with MHC1. They recognize it through MHC. Well, they don't recognize glycopeptides in general, actually. And it's not D, because remember, IL-4 and IL-5 is released by T helper cells, and not by cytotoxic T cells. They mainly release perforin and granzyme B, which should have been the answer, which is B, which majority of you put. So well done. Okay, that was it for the lecture. If you guys wanted the lecture along with a few more notes with it, that should be on the PowerPoint.